Thank you all for joining us today. This is our first of our 2022 series of RHC webinars. We will be recording the webinar today and then posting it on our YouTube channel later on, hopefully in the next few days. We have Kate Hill joining us today, as well as Jonathan with Stroudwater. And Kate will be going over Compliance 101 and the hot topics, and also discussing some new things at the end. So as usual, these are informal. We want to be as interactive as possible. So if you have questions, please feel free to put them in the chat. I'll be watching that. You can unmute yourself. So if you want to unmute and ask a question, do that. But we want these to be as informative as possible. And so with that said, Kate, I'll turn it over to you.
Okay, thanks for the invitation. Happy to be here, even if it's virtual. And I'm going to get started. And I will say, if you have a question, we're a small enough group that a question of something that's on the screen, please either unmute yourself and ask, or get Lara to tell me the question. And let's get started. Lots of time for questions at the end. Okay, so we're going to talk first about the PHE. A lot of more information keeps trickling out, nothing official. Right now, we're looking at April of 22. The secretary said he would give us 90-day notice prior to extending, so we didn't get that. So we suspect we're now at July. That could be the end of it, or it could not be the end of it, but just that you have fair warning for the things that you're living in an 1135 waiver will go away on that date of the end. So be very careful, with the exception of telehealth. And you have, for some strange reason, and there must be a good reason, 151 extra days to do your telehealth at the end, from the end of the pandemic, which just happened this past week. And so just bear that in mind. We're good otherwise. So I think the best way to keep your self-survey ready is to do regular mock or self-surveys within your clinic. And so let me give you a couple tips on that. You want to get your team together and hold a little kickoff conference to discuss how we're going to do this survey. Then with a walkthrough of the clinic with your checklist in hand and a red pen, I will say, and then make sure you can answer yes or check yes to all the questions, and then that big red circle for areas of concern that need more attention. Then sit down and do a policy review based on the policy section of your checklist. Do you have all the policies? Are they complete? For provider-based clinics, are there parts in there that need to be specific to the clinic, particularly things like infection control? We see this a lot, where you use a hospital infection control policy, and it's talking about operating rooms and things like that, which of course you do not have. So make sure you're clearly identified in those policies. Interview your staff to make sure they're knowledgeable about your policies, procedures, and their individual job responsibilities. Now, they should be comfortable answering any questions relevant to their job. They also would not be expected to answer every question ever asked, but they should know where to go for the answer. And so let me say on that little part, make sure you share your wealth of knowledge. If you're listening and you're the clinic manager, please, when you're not there, surveys tend to go sideways very quickly because the staff can't find things. Where are those? Where's that policy? Where do we keep that license? All those kinds of things. So things like that. Make sure you include some other people in. Make it a team project and you'll do very well. Many eyes are always better when it comes to compliance than just yours. And then, of course, have a wrap-up conference to discuss areas of concern, make some assignments, and then be ready to celebrate your accomplishments. You have worked hard, as your staff has, to stay compliant, and the survey's their time to shine. And it's an open book test, so we shouldn't be failing. We should know exactly what's going to be expected of us and have it done. Okay, so enthusiasm, not apprehension. There's always a little bit of apprehension because you don't know what you're going to hit, but we hope it's a fair and unbiased survey, and they'll show themselves off. So you do need a checklist. This is our checklist. You can take your regulations and make a checklist, and that's really a good thing to do. And then let's get started. So regulatory priority number 10. We'll work right up to number 1. It's the old 50% and the 51%. So 491.8 says the nurse practitioner, PA, or midwife is available to furnish patient care services 50% of the time the RHC operates. Make sure that is happening. Now, that is under an 1135 waiver, so that if there is an NP or you don't have one right now, or she's at the hospital or out sick or whatever, you're covered by the 1135 waiver. I would document the dates and the times that she's out for now to cover yourself. But the minute that waiver and the PHE ends, we're back to 50% of the time. Remember that nursing home visits, admin time count toward that 50%, but you must document those things in your wherever you keep records like that. And 491.9 is 51% primary care. This is a huge hot topic right now because we know we need a lot more involved in that 51% than we're getting, particularly mental health and some other specialties. But for now, that's what CMS interprets this as: primary care, women's health, and pediatrics. And make sure that you are in compliance with that and not out of whack with too many specialists pulling that the other way. Number 9 is incomplete charts. So at 491.10 is the list of things that make a complete health record. We see commonly missing consent forms. And what happens some of the time is that you have a piece of paper that the patient signs, and then it doesn't get scanned in, and we come and do a survey, and then they're missing. So you don't want to be missing consents. On the consent, the second piece of that is your consent should have a line for relationship to patient for a minor or someone incapable of signing. So you have some responsibility for that visit. So make sure you have that. And we always look at 2 minor charts on every visit. And the next most common under patient health records is the reporting of lab results. So this is test results, labs and diagnostic tests. Make sure, particularly for abnormals, that this is noted in the record that the patient was contacted and the findings were discussed. And we're going to look for that every time we see test results in the file. And there's what's in the 491.10 for records. So these are the actual elements of what's called out. And so we don't see too many errors with that with EMRs, of course. So you can use this as a chart for your QI checks, and you should be doing some every month, every quarter to feed into your biennial evaluation. And we're going to talk more about that in a minute. And here it is, the chart audit, number 8. So the program evaluation calls for a representative sample of both active and closed clinical records. So 10 per quarter is a great number. The federal government does not give us a number. The states don't give us a number. So what's your biennial evaluation going to look like? If you do 10 a quarter, you've got at least 7 quarters, maybe even 8. You've got 70, 80 charts to put into that file. And you don't want to wait till the last minute. Number 1, you want to find out if there's issues long before 2 years from now. And number 2, you want to have that ready for that biennial eval. We're going to talk more about how that's missing right now in some areas, and we don't want that to happen. So what is your definition of representative? Like I say, 10 is a good number. Now, if you see a problem, you're going to evaluate more charts. If you're good, then 10 is a good number. Make sure to include a closed record. You don't have to even do it every month or every quarter, but now and then. So what's your definition of a closed record? Number 1 is obviously a patient who's deceased. Number 2 is someone that's asked for their records because they're transferred or they move away. And number 3 is your definition. Mostly that sits at 2 or 3 years, but have a definition of how you define a closed record. And then mark it. If you're doing 10 charts and one is closed, mark it closed so that when you do the biennial, the surveyors are going to look for that you've evaluated some closed records. And believe me, 2 is good. Nobody gives a number for that. We would never fuss over that. If you've looked at a couple closed records, you're good. But identifying them is really important. And then you throw those each quarter into a file, and you're well on your way to getting your program evaluation done. Now, missing elements in the emergency preparedness plan is hit number 7. So in your emergency preparedness, all the things that are included in that. Number 1 is including safe evacuation from the clinic, which includes appropriate placement of exit signs, staff responsibilities, and the needs of the patients. This comes up in your fire drill. This should be no surprise to anybody how you do this. A means to shelter in place for patients, staff, and volunteers. And that's if there's a disturbance in the parking lot, if there's a chemical leak next door. I'm in Kentucky right now, and I'm down the road from the largest chemical dump in our country, a military base. And so they have special plans here, should that thing ever go, and to keep people safe. The hospital actually has special carbon filters, and they can lock that place down in case there's this chemical leak outside their building. That's not likely for your neighborhood, but you might live near some kind of chemical plant for sure in rural, absolutely. And then the other thing is, of course, for a tornado, why we need to stay indoors. Now you see that word volunteers. and it skips down to the second to the last bullet. If you have volunteers, you must name them in your policy. You must train them on HIPAA and on your emergency preparedness. We have found that that's more a hospital reg, and we'll accept that you do not have volunteers. So, but you must call that out in your policy. Otherwise, that's one of those check boxes that can't get completed. So don't forget to do that. The third bullet, a system of medical documentation that preserves your patient information. This is about a tornado taking out your building or a fire, and you had your backup for your EMR in the building. So we want it somewhere else. Geographically distant is the definition. That's across the street in the hospital, or in the in Tucson in the cloud. It's somewhere else, so that if your building goes today, tomorrow morning, you can open the laptop and see patients somewhere. And that's the whole reason for that. And of course, your HIPAA, you have to protect your patient information. Now your complete, excuse me, communication plan is the name of every person that works in that clinic and their phone number. That's really that simple. Every doctor, every non-physician provider, every nurse, every person. And that's, keep it updated as best you can. I know for some of the bigger clinics, that's a challenge because of turnover. But fact is, nobody's going to argue if Mary's no longer working there and her number is still in your policy. More importantly, is the new person get added, and that's always easier to remember. And then the training. So with your emergency preparedness, you must train your staff. And so do you have an attendance sheet, and what did you train? And they should sign it. And then now, if you're doing an online kind of training, if you've got it in Silverstream or something like that, and you can just print it out and that proves that they did it, that's fine as well. Number 6 is no documentation of the event, the exercise, or the tabletop. And so let's for example say that in 2021 you used COVID as your event of the year, and certainly it was. So let's have a meeting. Let's talk about what we did right and what we did wrong, and write it up and sign it. And that's your analysis. You must have that, even if it's just for a tabletop. All of those require that evaluation. This is the CMS form. It's called an after action report. If you Google CMS AAR, it'll come right up. It comes with instructions. The form is wonky, truly, and you can just take the elements that are there and put them in a Word document, and you've got your after action report. And here's what's in there. So here's a little bit about, you can borrow this one for your COVID. For 2021, even into 2022, because we're still in a public health emergency. And it's actually been very different. So we're accepting this for 3 years running. 20 was the beginning of it with, oh my goodness, there's a pandemic worldwide. What are we doing? And all the things that we lived through at that point, signs on doors and PPE and hand sanitizers. And then in 22, we got to vaccinations. And now in 21, and now in 22, we're at a whole different stage where we're weaning off of this, but we still have vaccinations to deal with and policies for that, and still some concerns for the virus, of course. So you write up a little summary. This event, whichever year you're choosing to write it up for, occurred as a result of the coronavirus, which resulted in a worldwide pandemic. The emergency team at our clinic was composed of, and you list your staff. Our major strengths were staff trained on infection prevention, triaging patients at the door, putting a sign on the door, go back to the car and call us. And where did we need improvement? Order extra PPE, masks, sanitizer, the need to minimize things in the waiting room. So this is the early one, and more like in 2020. It's changed as we went through the 3 years here. And you have to do one for every year, right? Need for more screening of clinic staff, temps in the morning, refill process. We made that easier throughout the pandemic so patients didn't have to come in. Need for more telehealth, of course, public service announcements telling the community that we are seeing patients or we're not seeing patients. You need to change your messaging on the answering machine. And then we got into more local testing. And so what did we do well? Well, we immediately began calling patients instead of visits to decrease exposure. Some staff was sent to the hospital to assist with surge. We recruited some experienced staff from the hospital to help with triaging. Signs on the door, limited seatings in the waiting room, extra hand sanitizer and tissues. And so celebrate what you did. These are just examples from clinics across the country as they chat with me. And so you'll put yours in there and you type this up and you have your after action report. Don't miss that. And then a summary is to describe the event as successful or unsuccessful and state areas in which subsequent exercises should focus. So what did we learn and what do we need to practice more? What do we need to work on? And probably staffing is the biggest thing that I keep hearing, where we're still struggling with that. Number 5 is expired medications and supplies. So remember, when you're doing your monthly checks, everything in the clinic that has a date, whether it's iodoform gauze or cotton tip applicators, gloves, needles, syringes, medications, of course, they all have dates on them. And the surveyors are going to look at those things, and you should be too. Now, some things you can still use that are not sterile as long as you label it not sterile for other use. Fine. Nobody's going to cite you if a Post-it note can save you a deficiency. And so bear that in mind as you, and not on medications, but on the other supplies. Your sample room needs to be organized so that you can see those dates very quickly once a month. Now, the box on the right was done by a West Virginia clinic years ago, and they put 12 different colored stickers, and they stickered those drugs as they went into the closet, which saved an immense amount of time on a monthly basis looking for outdates. And so you can borrow that method as well. It works really well, especially if you have a lot of samples. Watch for controlled substances in your sample closet. Once in a while, they'll slip in, and you need a separate log for those drugs. You don't want to miss out on that. Number 4 is the physician chart review documentation. So the physician, MD or DO, must review non-physician provider charts. Even in a state where there's autonomy for those folks, you still have to do it if you want to be a rural health clinic. So he periodically reviews the clinic's patient records, some for each NP or PA. And I'm remiss that I didn't look it up before we started, whether your state has a number. If they have a number, then of course that's the number. If they do not have a number, then you, and most states do not, you must choose your number. So if you have a real experienced NP and she's been with you for years and you know her work, then pick 10 a quarter, pick 5 a quarter. It's fine. But make sure you can show the surveyor who were the 5 charts that were reviewed last month, last quarter, whatever it is, and have it in a policy, and then have a log, the patient names, the date, and the signature of the MD or DO at the bottom. You've got to be able to document, if we can't see it, it hasn't happened, right? And so this is a common deficiency, not that you didn't do it, that you didn't document it. And of course, if it isn't documented, it didn't happen. Number 3. The policy review signature page. I can't tell you how many times we cite this. This is a simple fix. So the policies are called to be reviewed, patient care policies, every 2 years. So how do we ever know you did that? You got a big old binder. Well, you have a signature page at the front. And if they're electronic, have a signature page electronically. And the 3 people that need to sign it are the MD, an NP or PA, and a person who's not employed at the clinic. That's somebody at the hospital. If you're an independent clinic, it could be a pharmacist in town, somebody that's a professional, that's capable to look at your policy and say, hey, these are great, this is fine, or no, I have a question about that or something, every 2 years. So look back at your policies today, look at this page, signed by 3 people, and make sure that date is never older than 2 years from right now, so that if you have a survey tomorrow, you're covered on that. Make sure that you get that done. Now, during the pandemic, we've seen no evidence of a biennial program evaluation. I think maybe because people usually do it at a meeting and get together to discuss the results, that they thought they shouldn't have to do that because there was a pandemic. Well, it was never covered under a waiver. So you must arrange or carry out a biennial evaluation of your program. And that evaluation includes review of your services, including at least the number of your patients served and the volume of services, a representative sample of closed and active clinical records. That's your QI that you've been adding up and putting in that folder over the last 2 years, and then your policies. And then the purpose of all that is to make sure your services were appropriate, that you followed your policies. We're doing our policy review right now, and we're finding, oh, we don't do it that way anymore. We changed that policy a year ago. And so it's normal. So you review your policies and you update them as needed. And so the law requires that you do that every 2 years and that you followed your policies. We see policies that say you're doing this and you're not doing that anymore, or vice versa. You're doing something that's not in your policy. So you make the changes that are needed. And then again, it's another evaluation. You evaluate what you found and write that up as a nice little term paper, and it's good to go. And then you do another one just shy of 2 years from now. When you miss that, it's a failed survey, condition level deficiency. So, and we've had them through this last couple of months. It's very hard for me to take that should fail your survey because it's an easy fix, but you just didn't get it done for many, many reasons. You've been very busy with the pandemic. Maybe you thought there didn't need to be this right now, whatever the reason. It's not waived. You must do this. So when you get off this call, go look at the date on your biennial evaluation and make sure it's not more than 2 years old so that you don't get clipped on this for a survey. Okay. Now you can save yourself the condition level part of this deficiency if you've got pieces and parts of it done. If maybe you've reviewed your policies and you've got numbers of patients that you've served over the last 2 years, all that. So then it would just be a standard level deficiency. You're missing one piece, perhaps you didn't write it up or something. So you make a quick fix on this. When you don't have any of it done and it's a failed survey, we have to come back within 45 days, or the state does. And that's a real short time to get all this done. So you don't want to risk losing that billing number if you didn't get your biennial evaluation done. Really, really don't want to do that. All right. The number one deficiency over the full 2 years is improperly managed medication vials. This comes up at 491.9, where you have your policies and procedures for handling administration of drugs and biologicals. We are still seeing, and I'm sorry to report this, single dose vials with a 28-day date on it. We had a train wreck of a survey last week with several of these. That is a clearly failed survey because you don't know if your patients are getting safe or effective medications. It's a real big problem. First of all, it's about the patient. We want to make sure they're getting safe medication delivery, right? So don't assume your staff knows the difference. That has really happened. A little MA last week said, oh, I never knew there was a difference. And nobody knew it. Nobody questioned her. She delivers the meds. The NP tells her what to give and she gives it. So it's a really big problem. And it was a really big failed survey. So possibly a staff member doesn't know the difference. I know most of you are rolling your eyes about that. I do too. I still can't believe it, but it's happening. I promise you, we're witnessing it. Possibly a certain drug comes to you always as an MDV, but right with all these supply shortages, your supplier sent it as an STV and nobody noticed. Go back and train. And also storing them on the same shelf to make it easier. It's good to separate them. STVs here, MDVs there, so we don't get confused. But basically, retrain. Please go back and retrain your whole staff right now, tomorrow, today, whenever, to pick up a vial, look at the name of the drug, look at the dose, look at the expiration date, and is it an STV or an MDV? Please. And by the way, when you date an MDV for 28 days, it can't be 28 days past the expiration date of the actual vial. We had that happen, same clinic last week, not in your state. So that's ridiculous. They were so intent on getting a 28-day date on there, they didn't notice the thing expired in 2 weeks. And so you have to use that date. Obviously, that vial expired medication. So train your staff why this is true about STVs. They don't have a preservative. There's no preservative in there. It's once and done in the trash or in wherever you put your vials. In the drug closet, separate them and possibly label all STVs. There's little red stickers that the pharmacy can get you to label STVs to make that point. If you penetrate the top of that STV, technically it should go in the disposal. Now, if you penetrated it and you didn't use it today, it is open, but you may use it later today. I would put that in a special spot so I could till the end of the day, and then you're going to have to get rid of it. So once and done. Anything single dose, anything once single use is done as soon as it's used one time. So we never want to use those for more. So a clinic in the Great Northwest had a problem with this, and they had a great little system. I'm going to tell you about that little red bucket right there. For a month, they had a system where if you removed a vial from the med cabinet, nobody could return the vials to that cabinet except one nurse a day assigned to that red bucket, and she would check every one of them. And they found their culprit, and they retrained, and they don't have that problem anymore. So every once in a while, it might be a good idea to do such a thing as that, and to make sure that we're doing this properly. 28 days for the multi-dose vials, and of course, never beyond the beyond use date on the label. Okay, let's switch to policies. So what are the policies that we have to have? We must have corporate compliance. Anybody that bills Medicare must have that, which must include standards of conduct. And every person should know what it takes to get fired around here. Is it posting on social media? Is it a certain dress style? Is it language, behavior, hair color, whatever yours is? They need to know that it's not acceptable in your clinic. And then the OIG exclusion list is an annual check on every person that works in your clinic. If they're on that list, they are not to be employed at your clinic. We did have an incident where a young nurse, before she was a nurse, worked for a DME company, and that company was convicted of some fraud, and her name was never removed. And so we all learned that you have to write a letter to come off the list. I was not aware of that. And so just make sure nobody's on that list in your group. We've only had 2 in 10 years that were on the list, and one was quite guilty. And so that person is no longer at that clinic. The other one was just an error. So you have review, policy. So how often are we reviewing our policies? The answer is every 2 years. We make sure we do those. The maintenance of health records, who's responsible for that? For you provider-based clinics, that's going to usually be somebody at IT at the hospital. But in the independent clinics, you have to put yet another hat on and make sure health records are being completed properly and safe and secure, particularly as HIPAA. And what is your HIPAA policy? How do we keep all of this information safe from hackers, et cetera? Your emergency services box and the contents of that box. So CMS is now allowing you to decide what goes in that box, which is absolutely as it should be. And so your NP and your medical director decide what goes in that box. The list should be in the policy, and we like it near the box so we can compare the two to make sure they match, because the medical director signed off on that policy to say, hey, this is good. These drugs are good. Don't forget to check the box on your monthly rounds. You don't open it very often, thank goodness, but you do need to check for outdates. The easiest thing is to put the next outdate on the top of the box, so you don't have to open it every month if you don't need to, because you know what's in there, the next one when it expires. Housekeeping policy, including disposal of regulated waste. Now, if you have a service for your housekeeping, you really don't need much of a policy, because you've paid somebody to come in and keep your clinic clean, but you do need to have a process for your disposal of your regulated waste, your sharps, your medications, those kinds of things. Your hiring, training, and orienting or onboarding of personnel. If you're provider-based clinic, that's typically done by the hospital and by the hospital policy, and that's quite acceptable. But you must have a note or a page in your binder that says your clinic follows the hiring, training, orienting policy of XYZ hospital. So, and that's always one. Why would you have a different one? It would be very odd to have a different one. Quality improvement. What are you doing to keep yourself sharp? That's mostly your chart review quarterly. Your biennial evaluation, we hit that one already. Your equipment management policy. So how do we clean it? How do we store it? What gets calibrated? How often? How do we know what gets calibrated? We look at the manufacturer's instructions for use. So we know, oh, this needs a battery and a light bulb, but this one needs an EKG unit, needs to be calibrated on an annual basis. Of course, infection prevention is a very large policy because it's a very necessary one. Now we have it in 491.8 that we have a reg to cite against, where there was not one before. All it said was clean and orderly clinic. So that's really important. Your patient care services. How do we care for our patients? What are our processes? Your pharmaceutical services, I want to hit that one separate, and it's coming up. And your emergency preparedness is a big policy, of course. And then your COVID mandate policies. And we are going to review those today. Coming up, because they're the newest ones. And I'm going to tell you, CMS is what's the word I want? Diligent about this. We have to report weekly to CMS on every survey with regards to the mandate. It's been amazing and quite a burden, but it is what it is. It's got to be done. So let's talk about your pharmaceutical policy. So you have written policies for the storage, handling, and dispensing of drugs, biologicals, and supplies. You're going to have a statement that drugs are always stored in their original manufacturer's containers to maintain proper labeling. You're going to have in your policy how you handle multi-dose vials and single-dose vials so that everybody that handles drugs reads those policies and understands how this is done. You're going to have requirements that drugs and biologicals are dispensed to patients with complete labeling. We don't see much of this in the clinics. Certainly, we don't see dispensing pills in an envelope like the old days because there was no pharmacy open till 8 o'clock tomorrow morning. But if you did that, you make it clear label on that envelope. Not that you can't do that, but you have labeling. If you dispense a sample and you don't want it taken the way the manufacturer suggests, you have maybe 6 hours or maybe only PRN, then write it with a Sharpie on the box. We're good with that, but just make sure you're clear to your patients what you want them to do. Requirements that you sorry, I thought you weren't hearing me. I've had a text there. Requirements that you regularly monitor the inventory in your clinics. It's very, very important. And I will say this: if you have a large clinic, and you have Mary doing this side of the hall, rooms 1 to 5, and Susie doing this side, switch them up because it's just like typos that I've already caught 3 on here. That I've looked at this 100 times and I didn't catch them before. So that kind of thing. You see what you want to see, and so we want to make sure we don't miss things for that reason. How you handle outdates in your clinic. What's the process? Are they picked up? Are they must still be locked, but they're labeled that they're outdated drugs. Storage in a space that provides proper humidity, temperature, and light. And of course, that is not to keep them in the heater room. And we've seen that as well. And how you handle refrigerated medications, critically important. You either have a data minder or you use logs and you check the temperatures twice a day. No drugs in the door of the refrigerator. And the CDC says, let's put water bottles in the door to maintain proper temperature. Now, if you're state surveyed, and you have those water bottles there, we have had a situation where the state surveyor called that food. And if you're worried about that, then I would label all those bottles not food per CDC and just leave them there. If you're not drinking those water bottles, there to take up the dead air space to make the body of the refrigerator a more even temperature body. So on the refrigerated meds, I always ask this question. It's 5 o'clock Friday night. You're all getting ready to go home. And the power goes out that night with a storm. It comes back on Sunday afternoon. It's been off all weekend. You're in Monday morning. It's back. And it's in range. How do you know the drugs are safe? You must be able to answer that question, whether it be a generator, whether it be a data minder that's alerting somebody to go move those drugs to a refrigerated spot. A lot of different ways, but you have to be able to answer the question so that we're always delivering safe, effective medications. Requirements that current drug references are on board is in your EMR now. So we no longer look for a book on that. It would be out of date so quickly. Antidote information, of course, is your poison control number. How you handle controlled substances needs to be in your policy. You have a separate log for them. You have special licensing perhaps for them for ADD drugs, those kinds of things. And every dose is accounted for within the clinic and they're secured in a locked cabinet. And that record keeping is very, very important. That's why I say watch when one slips into either in your emergency box or in your samples. Okay. Now, on the administration of scheduled drugs for the NPs and PAs, we do not drill down to that. That's the medical director's job or the supervising physician to see that their DEA allows that. We only look that she has a valid DEA that's in date. All right. The Poison Prevention Packaging Act has not been updated by the federal government since 1970. I don't think anybody ever looks at it anymore, but we should say that we live by that for sure. And that all prescribing is, of course, done within applicable state laws. So we never have signed prescriptions for any controlled substances without a patient's name on it, written by some MD who's not in the clinic, and it happens. So never, ever do that. That will certainly be a failed survey for sure. Okay, let's talk for a second about the vaccine mandate. You are now past the 28th of March, so you are expected to be 100% compliant. One state left to go. Good old Texas doesn't have to get there till April 14th, but everybody else, the whole 49 states are all there now. So you must be compliant. And it's, as I say, very, very rigidly supervised right now by CMS. So you have vaccination policies that ensure all staff are fully vaccinated or exempted. We'll talk about that. You have a process for ensuring that you follow nationally recognized infection control guidelines. And that's the new little piece in 491.8D that came to us. So what is your process? So mostly you're using the CDC, or you're sterilizing your instruments by one of the guidelines, maybe AORN or one of those, okay? But what's your process for keeping everybody safe in your clinic? You have a process for tracking and documenting the vaccination status for all staff. This is really important. We're expected to see a log of spreadsheet with everybody's name that works in the clinic, their vaccination status, vaccine check, religious exemption check, and medical exemption check. And then they total it up and you get to your 100%. That includes all three. Then you have a column for boosted. Who got a booster? Boosters not required. Tracking the boosters is required. I can't tell you why that is, but it is. It's in the law that got passed. And then what's your process for exemptions? So what is your process for accepting a religious exemption? We are not to question a religious exemption, nor would we ever. If we have a religious exemption, your form, and it explains that I'm having a religious exemption and I've signed it and dated it, it's accepted. But you have to have your process on what you're going to accept for that. And of course, medical exemptions are a little different. They're more controlled and regulated by the CDC guidelines, and you'd find those on the CDC website. And then you must have a contingency plan so that those that have a religious or a medical exemption, you have a written plan for how you're going to keep them safe. Is it masks? Is it testing on a weekly basis or something like that? Is it separation from the rest of the staff? What is your process? And so you must have that in writing. And all these things add up to a nice, healthy survey. All the policies are required. So your vaccination policies and procedures include all your employees, licensed practitioners, students. This is huge for big teaching centers, that those students, you must verify that they have been vaccinated. Trainees and volunteers, if you have them, and any individuals who provides care in your clinic. So I had a question yesterday about the cleaning staff that comes in at night and is out the door in the morning. Do they have to be vaccinated? I would say no, but I would want to see your policy. So your policy says something like all those who enter the clinic when there's no patients and staff in the clinic are exempt. We're not going to look. I would hope they'd be vaccinated, but if they're not, it's not your issue. There was a survey of a critical access hospital a couple of weeks ago where they were doing some construction. The construction workers were outside on the outside of the building, but they came in the hospital for lunch and bathroom breaks. And they were in the middle of a survey. And the surveyor asked about these construction workers. They were not vaccinated. And the surveyor failed the hospital survey because they didn't take into account these kinds of visitors to their clinic, and they were indeed in the building with patients and staff. So be sure of that. Now, your policies do not include any staff that's 100% telehealth, telemedicine. They're not in the clinic. They have no contact with patients, and that would, of course, be true for those cleaning staff that come at night. And then staff who provide support services for the clinic, but they're exclusively outside the clinic, are accepted as well. Must include at a minimum a process that ensures that all staff have received at a minimum a single dose vaccine or the first dose of a 2 series. So you can hire someone, they've gotten 1 dose and they'll get their next dose when the time is right. And so they're good. Okay. And then the exemptions, you've got those noted, but the special category for temporary delayed. You should be tracking people that have not been vaccinated. They're not exempted, but they're temporarily delayed. Perhaps they were sick, or they got monoclonal antibodies, or maybe they're pregnant, things like that. So you'll hit them later with that. So you just have to remember to include everybody in that clinic, every one of them. All right. I think that's all there. And then again, that nationally recognized infection prevention control guidance, very, very important. They slip that in so that surveyors can now cite infection prevention issues within clinics. There wasn't a clear place to put that before. So you must include at a minimum that process for tracking and documenting vaccination status for all staff, for all who have any boosters, for all who have exemptions, and then for all or on an await process for some reason. Okay, the clinical contraindications for medical are clearly stated on the website, but then again, that must be signed by a provider. It can be MD, DO, NP, or PA. And I don't think anybody's going to question those or signed by those people. Cannot be the person, and they put it in here actually, who asks for the medical exemption. Cannot be the same. You can't ask for yourself, is what I'm trying to say, and not getting it out very well. Okay, all information in the medical exemption, which vaccine is country. You can't just say Kate Hill is exempt from this vaccine, medically exempt. It's got to be the why. What is the vaccine and what is the reason that I can't, I'm allergic to something in there, that kind of thing. Okay. So we're talking about the policies for everybody in the staff. I think I covered this, but I did, but I don't know if you heard it. At a minimum, tracking. Tracking is huge. You've got to have this log and how we track everything. The vaccinated, the exempted, both religious and medical, the people on hold, and the people that have a booster. Okay, so make sure you've got that to show to surveyors. Now they're going to look at not everybody's card. We look, if it's 10 or less, we look at all 10. If it's 10 or more, we look at 10. So we're going to do random checks. You won't know who we're checking, but you're going to show the log to show that everybody is vaccinated. So make sure that you have that. Okay. And that other big thing that I just got finished chatting about was the contingency plan for those that are not vaccinated. Make sure you're covering them, keeping them safe, as you have done for the last 2.5 years. So this is where we want to get to. 40% or more of your staff are unvaccinated. You have an immediate jeopardy situation. These are CMS rules. This is not our rules, and that's a serious problem. Now, if you have 100% not vaccinated or are non-compliant with your processes, you could still have immediate jeopardy. Now, condition level can be you didn't meet the 100% and one or two more of your elements of your policies are not developed and implemented. All right. So that's 21 to 39% remain unvaccinated, creating a likelihood of serious harm. Condition level is a failed survey. Standard level deficiency is if you've got 100% vaccinated, and all new staff have received at least one dose, but you're missing some policies, but you're making good faith effort toward it. So you can see the problem here. If you're not 100% vaccinated, you're not going to pass survey right now. So and vaccinated includes your exemptions. So, one way or another, let's get that done so you don't have that problem. So are you survey ready today? At a minimum, do quarterly rounds with your surveyor hat on, document what you find, meet with your group, create a checklist to stay on track, and don't assume you're ready just because you function as an RHC and are taking fabulous care of your patients, because you're in a federal program and it's highly regulated. So we have to make sure we have that. So to ensure you have a successful survey, prep your team, read the regulations, ask questions, email me anytime, Jonathan as well, get clarification, review your EMR functionality, make sure everything's being captured, gather the documentation, keep it all together so that you make the day easier for everybody, for you, your staff, and the surveyors. Things go well when that happens. Use a checklist, complete a mock survey, communicate between team members. This is a team sport, don't forget that. Educate, implement, and follow up, and then complete those periodic environmental rounds to make sure everything is up to date. And that is it for me. What kind of questions do we have? Do we have any questions? We didn't lose the audience, did we?
I'm not seeing any questions yet. If anyone has any questions, Melinda, I see that you're unmuted. Did you have a question? All right. Is there anyone else in the audience that has questions? Susan?
I was just wondering, we will be able to get copies of these slides, correct?
Absolutely. You bet.
Thank you so very, very much.
Absolutely. With typos corrected.
Does anyone else have any questions? And I'm just curious, has anyone else been surveyed recently with the COVID vaccine requirement?
That's good to hear. So they aren't going to come out to do a COVID survey. That's a common question. They're not doing that. But if you're due for survey, the only other time would be a complaint. If somebody complains to the accreditor or to the state, then we have to, we'll resolve it first if we can, but if need be, we'd come out. And then while there, even if the complaint did not relate to COVID, we would do the COVID survey as required by CMS. So that's something to think about as well. For the most part, we have only had 2 failures since this began with the COVID mandate. And one was so sad, 100% vaccinated and not one policy. So you do have to write those policies. You can get them off the NARC website. You don't have to create them, just copy them, download them, and then edit them, put them on your letterhead, and you're good to go. And that's really, there's no reason to miss that. So make sure you have that. The other one wasn't vaccinated enough, but the other one was just a sad story when they got through, everybody's vaccinated and not enough, no policies. So if you have questions or you'd like to know more about a certain topic that we talked about, perhaps emergency preparedness webinar, anything like that, let Lara know and we'll be happy to do that for you.
And I think I missed, what website is that you can get those COVID vaccine policies from?
Oh, National Association of Rural Health Clinics, NARC, NARC. Yep, they're there.
And when I send out the slides, I'll look it up and send you guys the link to access it.
Good. Good. And Lara, I'm going to travel right now, so I'll get those to you this weekend. Okay.
Sounds good. All right. Jonathan, did you want to add anything?
No, again, anytime we're able to get Kate on here to provide, a lot of this critical information, I think it's highly valuable, especially because it's coming directly from one of the surveying entities itself.
Yes, absolutely. Well, thank you, Kate, for your time, and be careful on your travels back home. Thank you all. And our next webinar is scheduled for April 21st, and I'll be sure to send out more information in the coming weeks.